Did you know that the rate of gastrointestinal cancers in people under 50 is rising faster than almost any other adult cancer type? It's true early onset, or EO, GI cancers are now a global concern, and the numbers are climbing every year. Let me set the scene. Between 2010 and 2019 in the US, incidence of EO-GI cancers jumped by nearly 15%. That's not a blip, that's a trend. And it's not just colorectal cancer, pancreatic, gastric, and even rare cancers like appendiceal neuroendocrine tumors are joining the list. Now you might be thinking, isn't cancer in young people mostly genetic? Surprisingly, while germline pathogenic variants think inherited gene mutations like those in BRCA or Lynch syndrome are more common in young patients, most EO-GI cancers actually happen sporadically, with no clear family history. So what's driving this upsurge? The birth cohort effect provides a clue. People born after 1,950 show higher risk, hinting that environmental factors, diet, obesity, and lifestyle are at play. And the impact isn't evenly spread. Black, Hispanic, Indigenous, and women are disproportionately affected. Here's our challenge. EO-GI cancers are not simply younger versions of old-age cancers. They bring unique clinical, molecular, and social hurdles. As we move forward, understanding these distinctions is essential to protect future generations. Why is someone in their 30s or 40s suddenly facing a cancer previously seen in retirees? The answer lies at the intersection of genetics and environment, two forces that can quietly reshape our risk profiles. First, germline pathogenic variants, or GPVs, are inherited changes in DNA. For instance, Lynch syndrome, caused by mutations in mismatch repair genes, is responsible for about 10% of EO colorectal cancers. But here's the kicker. 75–90% of EO-GI cancers arise in people without these inherited mutations. This brings us to modifiable risk factors. Obesity, especially when it starts young, increases risk nearly twofold. A Western pattern diet, think high fat, low fiber, and lots of processed food alongside sedentary habits, also fuels this fire. Another culprit? Non-alcoholic fatty liver disease, now called MASLD, is emerging as a silent driver, even in people who aren't overweight. You might ask, doesn't family history count for something? Absolutely. But for most, it's day-to-day exposures, diet, alcohol, smoking that tip the scales. Imagine your DNA as a loaded gun. Environmental exposures, pull the trigger. To truly curb these rising cancers, we must focus not just on genetics, but on public health policies targeting diet, activity, and early life exposures. Prevention is about more than genetics, it's about the world we build. Let's talk about the real-world experience of early-onset GI cancer. Imagine a healthy 35-year-old with abdominal pain and rectal bleeding. Too often, both patients and doctors dismiss the warning signs, leading to diagnosis at later, more aggressive stages. Here's the clinical reality. EO-GI cancers are more likely to be poorly differentiated, meaning the cancer cells look and act less like normal cells and spread faster. The term signet ring cell histology comes up often, a rare and aggressive form that's disproportionately seen in younger patients. On the molecular side, things get even more interesting. EO colorectal cancers, for example, show higher rates of microsatellite instability, MSI, due to underlying genetic mutations, but also distinct patterns like more TP53 mutations and fewer CRAS or APC mutations compared to older adults. Think of these as the cancer's fingerprints, unique patterns that may demand unique treatments. Now you may wonder, do these differences mean younger patients get better outcomes? Not always. Despite more aggressive therapy, survival isn't consistently higher for EO cases. The reason? Delays in diagnosis and the biology of the tumors themselves. Ultimately, early and accurate diagnosis, awareness of symptoms, and molecular profiling using tools like next-generation sequencing are key. The earlier we intervene, the better the odds, especially with cancers that don't play by the old rules. Here's a critical question. Are younger cancer patients being treated differently? And should they be? The data shows they're more likely to get aggressive, multi-agent chemotherapy and extensive surgery. But oddly, this doesn't always lead to better survival. For example, trials like Prospect and Oprah reveal that less can sometimes be more. De-escalating therapy in select rectal cancer patients preserves quality of life, fertility, and function without sacrificing outcomes. But this approach is still not the norm for EO cases. Let me tell you a story. I once met a young mother who, after months of symptoms, was diagnosed with advanced colorectal cancer. She faced not only intensive chemotherapy, but also challenges around fertility preservation and financial toxicity, a term describing the burden of medical costs that hits younger adults hard. Now, you might be thinking, aren't treatments improving? Yes, especially with targeted therapies for specific mutations like PARP inhibitors for BRCA-mutated pancreatic cancers or immune checkpoint inhibitors for MSI-high tumors. But access to care, insurance, and systemic disparities continue to affect outcomes. Black, Hispanic, and uninsured patients fare worse, regardless of age. Looking ahead, we need a multidisciplinary, equity-focused approach, personalized therapy based on molecular profiling, better screening strategies like FIT tests, and non-invasive tools and survivorship support. After all, cancer care isn't just about survival, but about living well during and after treatment.